Edwin Wong's. Okay. Hi, everyone. And yes, Potterhead, absolutely. So I have like my little wand over here as a true Harry Potter fan with my Harry Potter cup. So for those who are interested in Harry Potter, happy to chat more about Harry Potter as well. And thank you so much for coming to the morning to listen to my talk on sort of what we see in neurology, really common, which is sort of stroke. And we'll talk a little bit about what stroke is, how do we sort of manage it, and maybe discuss a little bit about why strokes even happen. So it's going to, all right, and so because this is your last day of the event, hopefully you are all super excited about the brain in neuroscience, just as much as me. So happy to chat more offline if you have any questions about medicine, neuroscience as a whole, teaching, etc. All right, so I'm just gonna share my slides. And actually, right before I do that, I know this is a bit of an international event. I just want to maybe 30 seconds, just type in the chat, where are you all from? I'm currently in Toronto, Ontario in Canada. So I was always excited to see people from international events. Oh, wow, okay. So we have Philippines, India, Bulgaria, Toronto. I think some of you are in my neuroscience course, so hi again. Bangladesh, Egypt, Pakistan, Turkey, Edmonton, Lebanon, Nigeria. Oh, wow. China. This is fantastic. All right, so keep it coming. It's always super fun to kind of see where everyone's coming from, but we all share a big nerdy passion for the brain. So this is going to be about a 45-minute talk, and then the rest of the last 15 minutes will be just more about Q&A, but I'm also happy to answer questions. I have my other computer next to me, so I can look at the chat box at any time. Okay, so let's get started. Let's see if I can. Oops. Find my camera. And how are you enjoying the event so far? It's good? Oh, amazing. Okay. It's also so awesome. Back when I was your age, we didn't have any of this sort of neuroscience extracurricular outreach program. So it's really fun to see how neuroscience as a field has been growing, but also young folks like you are slowly getting more and more interested about the brain, which I think is probably one of the most important and interesting organ. Not that I'm biased. All right, so as Salve sort of lovely introduced me, I'm currently an adult neurology resident doctor at University of Toronto, where I'm currently practicing in my training. So the agenda really for today is to do a quick little overview of just sort of my journey into research and medicine. And then we'll go into, introduction to neurology, but also specifically into strokes. And then we'll sort of wrap up with a case studies to see what you've learned over the last couple of, half hour. So I used to be a high school teacher, and I still teach on the side. So I always love using these little word cloud to kind of get to know my audience and students a bit more. So I want everyone to go on their phones or their mobile devices and just type in this website, www.menti.com. And then once you log on to this website, it will give you a link or a question. Let's see, there it is. So it'll give you a code you have to enter. So you can just put in the code 2109 2571. And once you are logged on, type in what careers and programs are you interested in pursuing or thinking about. And if it's not neuroscience, that's totally okay. I'm not going to hate you. So sort of health professionals, computational neuroscience, psychology, data analysis, chemical and biomed engineer. I find that engineers are probably one of the smartest people. No shade to doctors. Cognitive or computational neuroscientist, a neurologist with an oncology focus. Ooh, very interesting. Neurosurgeon, anesthesiology or bioeng, a cardiologist. We love a cardiologist. Biology, a researcher. Psych, neurobehavior, neuroinformatics. Oh, very, very big field right now, actually. AI, also very big field. Or a baker. Oh my God. See, I can't bake, but I like eating. So I would like to go to your bakery once you become a baker. And then just the last couple of things, just like more psychology and comp eng. Amazing. That's fantastic. It's very diverse, actually. All right, so then we have another question as well. Oh, and great. Someone's also giving more details of what they want to do, like an MD or DO or neuropsych. Amazing. All right, so the next question I have for you folks is, what interests you about the brain? So basically, why did you come to this event or this past week, actually? So everything, I love it. The vague and non-descriptive, everything, which is also basically the brain. It's vague and non-descriptive. I wonder if it's yummy. Interesting, interesting. Am I concerned? I don't know. The complexity? Yeah, absolutely. I think that's one of the main reasons why I went into neurology or neuroscience to begin with. Definitely versatile. The way disease is affected, how we think about dreams, thoughts, etc. It's incredibly multidisciplinary in consciousness. Yeah, for sure. I always like to, whenever I teach, neuroscience or the brain, I always like to begin with this philosophical phrase, the entire universe does not exist unless the brain is there, right? Unless the brain exists to actually understand philosophy or perceive philosophy or perceive the universe, sorry. It's kind of like meta in that way. Its functionality, how it relates to mental health. So yeah, just as important as is to learn how um, the brain normally functions is also really helpful to know what happens when things go wrong for diseases, for treatments, that kind of stuff. And research has been so expanding, right, within the field of neuroscience that it really is helpful from a clinical perspective. Things that we saw patients dying from or not being able to recover from 20, 30 years ago are now having significant improvements over the just past few years. So great. Thank you so much for chatting more. So I'm just going to go back to my presentation now. So I love the interactions. And if you missed putting into the Menti, happy to also continue reading it in the chat box as well. All right, so just a quick little intro of me, and then we'll go into the more important things. So Salve mentioned that I did my undergraduate studies at McMaster University. So for those who don't know, that is a middle-sized university at Hamilton, Ontario, sort of like north-ish of downtown Toronto. So I did mine in biology, psychology, did a minor in mathematics. This is me, I think, in first year in Halloween. I was dressed as a nerd during in my dorm, which really is not much of a difference right now. Not much of a costume when you are what you dressed. And then back in the day, I wasn't really interested in medicine. I was actually more focused on doing more research, learning more about advancements within the neuroscience community. So I decided to take up a graduate school program and completed my neuroscience degree in McGill University. So I primarily studied Alzheimer's disease and spatial memory and learning. Definitely encourage you to look into McGill University if you are interested in pursuing further research programs within neuroscience. I'm sure you've heard about McGill probably in the last couple of days, but it is the epicenter for neuroscience advancements. A lot of Nobel Prize laureates came from McGill within the field of neuroscience. Big discoveries have been discovered there and continuing to be discovered there in McGill. So I absolutely loved it there. I had this bit of a gap year, sort of figuring out what I wanted to do with my life after grad school. And I usually give a separate talk about this in terms of just being untraditional in terms of my pathways, but I actually became a high school teacher for a year prior to going into medical school. So I completed my medical school training at the University of Toronto. I should really update the slide. I am not a medical student anymore. And I'm started my first year of my residency training here at the neurology program at University of Toronto. All right, so really briefly, I think that as much as many of you are thinking of going to healthcare professionals or, more professional related programs, I also really encourage you to figure out what your interests are and take the time to explore that. Just because as you get older, you just have more and more responsibility and maybe less flexibility to do so. So I knew that I had a huge passion for teaching. I volunteered as an elementary school teacher back when I was a grad student. So I would come every couple of months and teach fourth graders about neuroscience. This is me showing a student about the brain. I think it's like a sheep brain. And I was also very fortunate to have been invited to give several lectures at McGill when I was finishing my grad studies. So I was teaching them about Alzheimer's disease, neurodegenerative diseases to second and third year university students. So overall, the teaching has been an amazing experience for me, but more importantly, not just because I enjoyed them, but I really find that it improved my communication skills. A lot of the soft skills that they don't necessarily teach you at school. I was able to learn many ways to communicate with elementary students all the way to university students. And that has served me really well now being a doctor. When I had different types of patients with different backgrounds of knowledge, I'm able to translate that more accessibly than maybe before if I was not having a lot of these teaching experiences. And, this made me further my interest to do more teaching later on in my medical career. So that's something I'm going to do more of, is more youth outreach programs like this and integrate more medical advocacy within a younger population. So just really briefly, what is the next for me? I love giving talk. I love talking about neuroscience, science in general, and I love talking to you young folks like yourselves. So I want to find a career that combines a bit of teaching, a bit of clinical, a little bit of research. Again, teaching is a huge passion of mine, and it's never work when you actually do love it. And again, just want to do more work within the youth education sort of like realm. So that's sort of my background. Any questions right now about, and thank you for putting more about your backgrounds in the chat box. Really enjoy reading them. Leona asked, what made you decide to become a doctor? Yeah, so, I think doctor was not something that I originally wanted to do, but after being a high school teacher, I wanted to expand sort of my teaching portfolio in a setting where I'm able to also continuously learn more. And medicine is something that if you love learning, you will have forever to learn more. You'll never learn everything or be the master of everything when you're in medicine. So that's always exciting because I don't like to always feel like, I'm bored or my knowledge is now stagnant. I also find that in medicine culture, there is a priority in teaching. You have to teach medical students, you have to teach patients, you have to teach their families. So there is a really significant overlap with education and sort of this, medical learning. So that's sort of like what's my perfect role. If I were to go into medical school, I want to have an emphasis in pedagogy in terms of education curriculum. So that's sort of why I want to go into it. All right, so keep the questions coming, but I'm going to move on to the next portion, which is sort of an introduction to neurology and vascular neurology. So this is the human brain. It's, as someone mentioned, hopefully not yummy, because hopefully I haven't eaten human brain, but this is sort of what encapsulates all of the universe, all of the senses, all of our emotions, and all of our memories, which is pretty phenomenal. In the chat, do you know how much it weighs usually? I'm Canadian, so we use a bit of metrics and also the empirical system, which is kind of weird, but an average, I probably only know it in pounds. Or in kilos if I know the mathematical conversion. Yeah, so I think some of you sort of alluded to it's about 3-ish pounds. So there is a bit of a diversity in terms of the weight, but about 3 pounds. It's not super, super big, but it is such a complex little structure. And I'm sure you all have seen about this, but the brain itself is organized into several major lobes or several major regions. So first we have the frontal lobe, which is sort of the anterior portion of the head. And then next we have the green area, which is the parietal lobe, which is on the top surface of the head. We have the occipital lobe, which is on the very back, and occipital lobe, as we can probably imagine, is important for vision. And that's why when teachers or parents are like, I can see you in the back of my head, that's where the phrase is coming from. And then the temporal lobe, which is right next to the ears. And this is just a sort of aerial view of the brain. So we have two big hemispheres. So this is sort of the longitudinal fissure that sort of separates our two halves. And within the functions of the lobes, can you tell me a little bit about what they kind of do? So let's start with frontal lobe. What do frontal lobe, might be responsible for? And then we'll quickly do the other 3 lobes. Yeah, cognition, absolutely. Yeah, definitely has a bit of language, decision making, thinking. Yeah. So you're really sort of thinking about executive functioning, right? I think someone mentioned coordination. So coordination is actually not so much frontal lobe. It's actually more of the cerebellum, which is the mini little bit in the bottom of the brain. Yeah, production of language. Yeah, Moshida. So you mentioned with the frontal lobe, we have something called Broca's area. So that is part of the frontal lobe. Yes, and M1, right? So someone mentioned M1, Jamila, that's the primary motor cortex. So really important for sort of big movements, right? Amazing. How about the parietal lobe? So parietal lobe, yeah, so memory is not so much parietal, but it's definitely related to a close structure nearby. Yeah, Ashmita, so it's more of a sensory for parietal. It has what we call the somatosensory cortex, or S1, so that's really important. It's also important for making sure that we're not ignoring certain things in our environment, so that's something called neglect. Or spatial lookout. Maybe that's what Moshida you're kind of alluding to, right? So even though our eyes are working, our brain sometimes ignores our visual fields if the parietal lobe is damaged. So it's really important for that. Amazing. How about, so we talked about occipital lobe, it's probably mostly important for vision. How about temporal lobe? Lastly, temporal lobe. Yeah, memory and hearing, exactly, right? So those are the main ones. And someone mentioned also emotion for frontal, but also very important for emotion regulations in the temporal lobe as well. Fantastic. And language comprehension, right? So that's the Wernicke's area. And just for time's sake, I'm not going to ask you about the brainstem or the cerebellum, but the brainstem is really important for, the autonomic systems, right? So we have 3 components of the brainstem. Starting from the top, we have the midbrain, then we have the pons, and then we have the medulla oblongata. And they're really important for regulating things that we don't necessarily think about, right? Our heartbeat, our breathing, our temperature regulation, etc. And then the cerebellum is really important for coordinating, right? Making sure that we're steady when we're walking, we're not just tipping over. When we're grabbing things, we're not shaking our hands to reach the target object. So that's amazing. So this is sort of the main stuff that you all correctly and astutely mentioned. And we have something called hemispheric specific signs. So there are actually regions of the brain that's more specific to the left hemisphere versus the right hemisphere. So the left hemisphere is actually predominantly for language. Most people are right-handed. So if you are right-handed, almost 99% of the time, your language centers are going to be predominantly on the left side. So if you damage the left side of your brain, you might have language problems. Very few, I think 10 to 15% of the population might have the language center on the right side. And the right lobe is something due to neglect, as we kind of mentioned before, right? So that's sort of the ignoring thing in our visual field. And that's specifically the right parietal lobe, okay? So if we damage the right parietal lobe, we're going to maybe have neglect. So that's just something to remember for the case study. So in terms of the brain, because it's an organ, like any organ itself, you need oxygen to be constantly supplied to ensure the tissues are alive. And how does oxygen go to these tissues? Well, it has to go through, our blood with our hemoglobin. And some people already sort of know a little bit about these blood supply. So just really briefly, our heart is down here, which is not part of the image. And the largest blood vessel that we have in our body is called the aorta. The aorta provides blood supply upstream and also downstream. There is a branch that kind of breaks off from the aorta to help supply the brain. Okay, so this is called the carotid artery. You can even feel the carotid pulse if you feel it underneath, sort of like under your chin to the side. You can feel the carotid pulse. So the carotid pulse or the carotid artery will supply blood flow to the front of the brain. You also have this other big blood vessel. It's called the vertebral artery, and that will bring blood supply to the back of the brain. And it is incredibly important because depending on where a blockage or an interruption of blood flow, you're going to have certain areas of the brain that might start to starve of oxygen. They might start to die off, and you're going to start to have symptoms, right? So again, someone mentioned before, this is something called the circle of Willis. So once it heads into the brain, the blood vessels, there's a very complex sort of distribution of blood supply called the circle of Willis. So it's actually not a real circle. It's sort of this like round sort of structure, but it supplies many different parts of the brain. And just a deeper dive of the circle of Willis, you notice here that you have sort of these big pieces of vessel that breaks off from the center of the circle. And these are called the middle cerebral artery, the MCAs. And then the very tip here is called the ACAs, or the anterior cerebral arteries. And then, you have a bunch of other vessels. But those are the main ones that I want to focus on today, is the MCAs and the ACAs. Okay. So the MCAs, as you can see, supply blood to all of these areas over here. You can imagine that this blood vessel goes in, it's going to supply all this different stuff, right? So all the lateral things. And then the ACA, or the anterior cerebral artery, is going to supply all of more of the midline structures at the front part of the brain. And there are a bunch of other vessels that I'm not going to go into today, but the MCAs and ACAs provide really a large amount of blood flow to the anterior part, the front part of the brain. And when we think about a vessel giving blood to certain areas of the brain, we can actually subdivide it into what we call vascular territories. So different parts of the regions of the brain will be provided blood from a very specific vessel, right? So I mentioned before that the ACA, which is denoted in A, and the MCA, which is denoted in M, provides one of the largest areas of the brain for blood. If you can imagine, if you lose one of the big MCAs, you're going to lose a large part of brain tissues right on the side, and that can be pretty bad. All right, so when I see patients coming in with strokes, I want to see what kind of symptoms they are having, because certain symptoms will be specific to certain regions of the brain, and certain regions of the brain have specific vessels. So even without putting them into like a brain scan, I can probably hypothesize based on like their movements, their weakness, maybe their issues with talking. I can probably have an idea of where to look for when I put them into a scanner. Okay. So if we were to dive deeper into the different vascular territories, so let's focus on the MCAs right now. The MCAs, if you can see, are more of the side structures, right? We have something called the homunculus, which is sort of this distribution of the primary motor cortex, as some of you mentioned before, in the frontal lobe. The primary motor cortex is really interesting because the way it's organized is based on different body parts. So the more middle part of the primary motor cortex is going to be more important for the lower extremities, like the foot, the legs, the hips. As you move to the side of the primary motor cortex, you're going to involve more of the upper extremities, like the hands, the arms, the shoulders, and also the facial muscles as well. So as you can see here, if I were to look at more of the side region of the brain here, you're going to see that the hands, the face, and the tongue all sort of correlate with the MCA territories, versus the foot, the hips, and the legs area, the more responsive or corresponding to the ACA territories. All right. So if I were to have a blockage to, for example, one of the ACA vessels, the anterior cerebral artery, I'm going to expect someone to come in with some weakness around their legs, but not so much weakness around their arms. Vice versa, if I were to see a blockage of one of the MCA vessels, I'm not going to see, or I'm not going to expect that much weakness from the legs, but I will expect weakness from the arms and maybe the face and maybe even speech, just because the tongue is also involved as well. Okay. And more importantly, when you injure a brain region, it's going to affect the opposite side of the body. Okay, so if I were to damage the right MCA, I'm going to see left arm weakness. If I were to damage the right ACA, I'm going to expect left leg weakness. Does that make sense in the chat? Perfect. So let me quiz you one more time. If I were to say, I see a left facial weakness, left facial, so someone's coming in with left facial drooping, which side and which vessel do you think is going to be affected? Left facial weakness. Yes, right MCA. Awesome. How about right leg weakness? Ah, you're so smart. You're all basically stroke neurologists at this point. Perfect. So it's left ACA, right? All right. So let's go into the first, the case study of the talk. So we have Mr. H. He is a 78-year-old male presenting to the emergency room around 6 p.m. His daughter, who was with him, mentioned he developed sudden slurring of speech with right arm weakness around 5 p.m. So it's about an hour difference. You notice that the patient also has some right-sided facial droop. He does not have any weakness in his left arm or either legs. He complains of his headache on his left side, but there's no vomiting or nausea. On his history, he has long-standing hypertension, so that's high blood pressure. He has diabetes, and he has something called dyslipidemia, which basically means high cholesterol. And he's on medications for that. He's also a smoker for many years, but denies any alcohol drinking or other recreational drugs. So recreational drugs meaning like marijuana, heroin, cocaine, that kind of stuff. Okay. So in the chat, what are some concerning symptoms that you notice of Mr. H? And you don't need to tell me exactly what's going on. You just need to tell me what symptoms are like, even if you're not in medical field. What's sort of scary? Yeah, so he's a bit of a facial droop, he has his headache, he has his vomiting, he has problems with his speech, he has this right arm weakness, right? And yeah, so the facial droop is definitely a big sign, right? Absolutely, I agree with that. And what are your differential diagnoses? So what condition might this be? It's a bit of an obvious one because I'm giving a talk on this topic. Yeah. But let me just challenge you a bit more. If it is not a stroke, even though I'm giving a stroke talk, what other things that could be that you might be wondering about? And some people are already putting in what vessel it is. Yep, it could be a TIA, right? So a transient ischemic attack. So that's basically a mini stroke, as I like to call it, where there is actually no sort of damage when you see on imaging. So we'll talk about that in a little bit. Yeah, you can definitely have a tumor, as Shmita has mentioned. So it's something inside the brain that's pressing on areas of the brain that should not be pressed. You can have paralysis. So, when we think of paralysis, we think of strokes, but we can think of seizures. So a patient coming in might have a seizure. Seizures can look like strokes sometimes. Absolutely. Amazing. And what's the most likely diagnosis? I think you all mentioned before, it's stroke. And some of you even talked about the specific vascular region that might be affected. So amazing. Yeah, and also, Aima, so I always wonder about trauma, right? So I always ask about like any falls recently, did you hit your head? Were you in a car accident? That kind of stuff. So common signs of stroke. So, this case, I've put it as much as I can about things that you might see on a typical patient with stroke. So has anyone ever heard of the FAST rule, FAST? Yes, okay, some of you have heard about it. So the FAST is a very good mnemonic for anybody, even not in medicine, to recognize if someone is having a stroke. So F stands for face, so is the face drooping? A stands for arms. You raise the arm, is there arm weakness that you can see? S stands for speech. So is the speech slurred? Is it much different than before? And time, right? So there is a phrase called time is brain in neurology. So the brain is a very precious tissue. The more time that there is no blood and no oxygen, no more cells will die, right? So you need to call 911 or emergency right away. So I have a little video that I'm going to share really quickly from the Heart and Stroke Foundation, which is really great at sort of illustrating signs of strokes.
He's been wanting to put garlic chives in everything.
Well, not everything.
Dad, the side of your face is drooping. Mom?
It's probably nothing.
Dad, are you okay?
You're slurring. Why are you slurring? Raise your arms up in the air for me.
Dad, are you okay?
Can you hear this, by the way, folks? I always forget to ask. Perfect.
Gracie, call 911.
I just
Honey? Tim!
Need an ambulance to send for
Tim, look at me, Gracie. Tell them to hurry. Tim, look at me, Tim.
Mom, what do I do?
Dad, I don't know. I think he's having a stroke.
I think my dad is having a stroke.
Tim, what's going on, baby? My husband, I think he's cold. Are you cold, honey? Are you cold? Okay. Gracie? See, Gracie's gonna come, sweetheart. We're just gonna go. We're just gonna go in the ambulance right now. We're gonna go to the hospital, okay? Okay. Huh? I'm right here. Gracie, meet us there. I'm right here, okay. Okay, here we go. You just stay right here. You just stay and breathe. Just breathe. Tim?
Dad?
How you feeling?
I'm fine.
Well, you've had a stroke. But because you got here quickly, you're looking at a full recovery.
Okay, yeah, so it's definitely one of the scariest things that a family member can sort of see if someone or a loved one is having a stroke. And it's definitely scary for me as well, even when I'm in the hospital. Someone asked a really good question. Why don't we look for leg weakness in FAST? So a couple of things, really good question though. So leg weakness is a bit hard to appreciate just because arms are so much easier to see. If people are already on the ground or whatnot, it's much more difficult to sort of get a good appreciation of your legs. And number two, most strokes are actually involving the MCAs, not the ACAs. So that's sort of a really quick way to sort of assess, right? And then the last thing, I don't think it spells well with L. So hopefully that makes sense. All right, so those are common signs of strokes. So there are different types of strokes, right? So some of you mentioned about bleeding, but there's also a bit of a blockage. Again, heavy medications be a reason for strokes. Yeah, so angina, yeah. So some certain medications can cause different types of strokes, and we'll talk about that in a little bit actually, or right now. So there are different types of strokes, right? So we have something called ischemic strokes and we have hemorrhagic strokes. So depending on the type of strokes, either one of these two, there's different types of management. So ischemic just means that there is a lack of, specifically a lack of oxygen. So in this case with ischemic, it just means that the blood vessel itself is being blocked. It's almost like a plumbing issue, right? If you have a blockage of a plumber, then water can't escape out of the hose. This case, there is a blockage somewhere here, and there is not enough blood supply to that particular area of the brain. Okay, so different reasons why you have ischemic strokes can be due to high cholesterol. So over time, your bad, poor lifestyles, habits accumulates in terms of the cholesterol buildup, plaques start to build, and eventually it'll cut off blood supply. You can have a clot somewhere else in the body that just traveled into the brain and then cause a blockage. And then you have hemorrhagic strokes, right? So hemorrhagic strokes essentially means that there is a bleed. So the reason why one of the area of the brain is not getting blood supply is because there is a leakage somewhere. So if you imagine using that hose analogy still, even without blocking the hose, if you have a leak, like you poke a couple of holes into the hose, you're going to have reduced water flow, right? Just because water is now escaping somewhere else. So that could be another reasons why areas of the brain not be getting blood supply. And a TIA, or someone mentioned before, a transient ischemic attack is just a very temporary blockage or a lack of blood flow to the brain. But this definitely is scary because you might be at risk for developing a full-blown stroke later on. So most strokes are ischemic. So that means a blockage of the vessels rather than a bleed, so hemorrhagic. So about like 85% of strokes are ischemic, about 10% is all hemorrhagic. But time is brain, regardless of either of these reasons, you need to see a doctor, go to the hospital right away. Just for time's sake, I'm going to not share this video, but I might share the slides so you can just kind of watch it on your own time. Okay. So in terms of the case study, same case. So this is Mr. H again, and some of you already mentioned before about where you think it might be going on in his head. But what are some risk factors for strokes? Let's go back a little bit. What are certain risk factors for someone to develop a stroke to begin with? Yeah, cigarettes. And Nabiha, you mentioned how do blood clots form? So it could be for a variety of reasons, right? You can have a genetic disease where your blood just naturally gets a bit thicker than usual, so you can have a blood clot. If you're not moving as much, you can develop blood clot because blood is not moving up and down as well. And certain medications can cause blood clots as well. Yep, so smoking, high cholesterol, lifestyle factors, right? Stress sometimes. Yeah, so stress on the vessels. Yep, obesity, smoking, high blood pressure, absolutely. So high blood pressure is very, very important. Drinking, yep, alcohol, definitely. Yep, certain genetic factors, right? Yeah, for sure. If you have a family history, I think someone mentioned before, if you have a family history of strokes in the past, you're automatically a bit more at risk for developing strokes. Foreign objects in the brain, I mean, like if you have like, a trauma to the head, for example, right? Yeah. Like an external sort of reasons why. Yeah, and another big one is probably diabetes. So diabetes, high blood pressure, high cholesterol, physical inactivity. So basically lifestyle factors, right? So make sure you're not a couch potato, you're trying to move as much, because then it reduces your risk for strokes and a bunch of other different diseases. And I mentioned before, or many of you mentioned before, which blood vessel and area of the brain is most likely affected. So many of you have written the right answer, which is a left MCA, which is amazing. So what brain imaging tool or things that you've heard about might you want to get this patient in quickly? So some of you said MRI, some of you said CT, some of you said MRI. So personally, for me, I love MRIs. It's my favorite sort of modality. But actually, the answer is a CT scan. So CT scan is the #1 thing we always need a patient to go into right away. And I'll talk about why in a little bit. And in EEG angina, not as urgent. If I'm worried about if they're having a seizure, though, I might get an EEG later on. So good thought, though. And what are some possible immediate treatments that can be offered to the patient? So I'm going to go into this in a little bit, but without spoiling some of the answers, I just want to hear what your thoughts are. What are some things that you've heard about people, being on medication-wise or therapy-wise for strokes? Alima says clot busters, amazing. Okay, I like that. Yeah. Ashmita, blood thinners, absolutely right. And other things, to think about is just like controlling blood pressures. Let me see. Matthew says a vasodilator. Ooh, so this is a bit of a very good thought, though. It is a bit of a controversial thing with vasodilators, because one of the reasons why we might be worried about giving a vasodilator is that if we dilate the vessels too much, would there be a risk for a clot to come out and then go somewhere else? Muscle reactant, or you're talking about muscle relaxants? Yeah, I mean, like if you're thinking about muscle relaxants, if they have like pain and whatnot, but not so much for a stroke per se. But I really do agree with the blood thinners and the clot buster medication. So that's number one or number two. So as you mentioned before, risk factors for stroke, so high blood pressure, high cholesterol, diabetes, smoking, big ones, right? And here is just another infographic which I found on the Heart and Stroke Foundation, really outlines some really big risk factors for strokes, right? And as some of you mentioned before, lack of exercise, obesity, if you have sleep apnea, so that's when you're snoring really loudly at night, heavy alcohol use, other sort of recreational drugs. If you have a patient that is pregnant, that's a bit of a high risk factor as well. Previous blood clots or in strokes is a big risk factor. Family history and other medications, right? So when we think about neurology and we think of a lesion or like a damaged area, we like to call it a lesion localization. Can you find or determine where in the brain this damage might be occurring, resulting in those symptoms? Because the brain is smart, but at the same time, it's kind of simple in a way. If you were to able to map out, you can probably figure out, is the left side that's damaged, right side that's damaged, which vessel is damaged, leading to the specific symptoms. So you all correctly said he has left MCA stroke, right? That's fantastic. So it's affecting the temporal parietal lobes. So just a quick little review again. This is the circle of Willis. You have the MCAs over here. And the MCAs originate from the carotid artery, right? That's like the big branch that comes off of the aorta. And most likely than not, Mr. H probably has a clot somewhere here, right? Remember, an ischemic stroke, which is basically a clot preventing blood flow, is more common than a hemorrhagic stroke, which is the bleed. So MCA stroke symptoms, as we all probably are aware of when we talked about it, you can have a facial droop just based on the homunculus. You can kind of figure out what sort of symptoms are there. So arm weakness, right? So not much leg weakness, but more arm weakness. You can have visual field defects, so meaning that you may have trouble with your vision per se. Sorry, just answer your question. And remember, they're all contralateral, right? So if you have right MCA blockage, you're going to have left-sided symptoms. Left MCA, you have right-sided symptoms. And if you have damage to the left MCA, right? Remember, language centers are predominantly in the left side of our brain. So if you damage the left MCA, you're going to have speech issues. Versus if you damage the right MCA, you're going to have what we call neglect, that ignoring of your environment. So the imaging modality that we like to choose based on guidelines is actually a CT scan when someone comes in suspecting of a stroke. So has anyone ever had a CT scan before? You don't need to share if you don't feel comfortable, but anyone had a CT scan done or had someone that they know of had a CT scan done? Okay. Okay. So for those who have CT scan, hopefully things are okay. But I just wanted to just ask the audience, just because, having a brain scan can be kind of scary. You're in this bit of a tunnel where you're in this sort of bed, and then you kind of get your picture taken essentially from the brain. So the CT scan really is a very fancy X-ray. I think most of us had X-rays before. If you had like braces or whatnot, they have to take X-rays of your teeth. They have multiple X-ray views, creating multiple angles to create this sort of like three-dimensional image of the brain. And the reason why we use CTs is because it is a very quick modality. MRIs actually take a long, long time to get images because MRIs are much more detailed. But CT scans, even though they're not as detailed or specific as MRIs, they give us a really good brief picture. And remember, time is brain. We don't want a brain scan that will take a long time before the patient gets treatment. And it's really good to assess big, bad, and ugly stuff, right? Is there a bleed? Is there a big, tumor or something inside the brain that we need to treat urgently? So I'm going to quickly just show you a couple of CT scans, because I think that's always a bit fun. Okay, so this is, whoops. Can you see all this? Yes, you can, okay. So this is a CT scan of a normal brain. So when we think of brain images, everything's a bit flipped. So this is actually the left side of the brain. This is the right side of the brain. This is the front with your nose. This is the back of the head, right? So I'm basically going from down upwards. So here's our nose. So we're going to go up. We're going up. We start to see the brain stems. And then here, does anyone know what these little things are at the very bottom? There are two lobes of it in the bottom of the brain. What these things are? If you had to guess. It's specific for coordination. Yeah, exactly. It's cerebellum, right? So this is your brainstem, this is the cerebellum, and now we're moving into what we call the cerebrum. Slowly, this is the midbrain. And essentially, again, this is right, this is left, right, left, front, back. We're just always trying to compare back and forth. Is there any symmetry, right? Is there anything that's on one side that's not on the other side? So here is a normal brain. Yeah, okay. Yep, the occipital lobe will be about right here, actually. Okay, so that's the normal brain. Really cool stuff, eh? So I'm going to show you this other brain. Not so much normal. So I want you in the chat box to tell me what you see as I'm going up and down the scan. So someone says space. So give me more information. Is it on the right side or the left side that you see something that's a little bit unusual? Yeah, on his left side, right? Yeah, so on the left, so we always say the left brain, right? Even though it's the right side of the image, it's actually the left side. Yeah, exactly, right? So there's a bit of what we call hypodensity. So dark images here, right? This is actually someone who had a stroke, specifically the right MCA. And this is a stroke that's probably about a few days afterwards. So you have this dark area. This is cell death or unhealthy brain tissue. Okay. So this is the left MCA. Perfect. Okay. And then last but not least, I'll show you a different scan. Hopefully you didn't spoil that. So again, tell me what you see on this one. Yeah. So pretty gnarly, not super healthy. So you see all those white spots over there, as all you mentioned, is kind of in both sides, but more predominantly on the right side of the image or the right brain, right? Blood is white in color because CT scans show things that are much denser in white. So this is all bone because bone is the densest part of the head. Blood is thicker than water, so blood will actually be whiter. So there is basically bleeds. So you notice there's a bunch of bleed everywhere. The bleeds, because again, blood is thicker than water, it actually adds pressure to the brain. So you notice here that it's actually squishing the brain, moving towards the left side, right? See this little gap here? It used to be quite symmetrical before in the other scans. It is now pushing it to one side. Okay, so this is not a very healthy brain. So as a very good astute neurologist, you order your stat CT, right? I don't know why I wrote the word stat. It's like you see in Grey's Anatomy or other medical shows like stat, order stat. But you suspect that there is a stroke in the left MCA. So you actually wouldn't necessarily see this right away. It actually takes a couple of days for you to sort of see a darker appearance. I'm just showing you this to illustrate that there is a stroke on the left side. Okay, so this usually comes about 2 to 4 days after the stroke. This is not Mr. H. This is a patient with a right-sided bleed inside the brain. How do you figure out the origination of a bleed from a CT scan? Great question, Nicole. So we can't. Based on a CT scan, we have to use something else called a CTA. Basically, the CTA CT scan would dye. So it actually will light up the different vessels. It's called a CT angiogram. So we usually do it at the same time. CT, and then we give them a dye, and then it lights up the vessels, and we see which vessel is damaged. As blood is thicker than water, if we have internal bleeding, shouldn't it look white? If we have an internal, I'm not sure if I understand that question, Krista. So blood is white if you have it on a CT scan. Right. So in bleeding, in medicine, we call it a hemorrhage. So this is a right-sided hemorrhage. All right. So lastly, interventions. What can we do? Right. So as some of you mentioned before, we can give a clot buster medication called a thrombolysis. So essentially, we can give it within a certain period of time, and it will destroy any sort of clots that are found in the brain, or at least hopefully destroy the clots. There is a very specific window of time. So if you remembered from the case that Mr. H came into the hospital at 6, but his daughter found him to have some symptoms at around 5 o'clock. So it's about an hour, right? So an hour is actually a great time point because he's still eligible to receive this thrombolysis medication. Anytime the patient is coming in a bit after this window, so after 4.5 hours, you actually have more side effects and more risk because you can have more bleeding, right? If you destroy a bunch of clots, you do have an increase of bleeding. And this is me last year as a med student giving my first thrombolysis clot buster medication. Apparently it is a tradition in neurology to take your photo whenever you give this the first time. So it will hopefully resolve a lot of the symptoms if you give it within a very short period of time. All right. And then the second thing you can also do is more of a surgical intervention. It's called endovascular thrombectomy, or EVT. So this is a procedure where you put a catheter, so like a bit of a small little tube, to remove the clot. So this one is a bit of a longer time span. You can, have this patient undergo this procedure within 24 hours. So a bit longer than the thrombolytic or the clot buster medication. And it's really helpful if you have a large vessel that's blocked, because this procedure, as you probably imagine, is much easier to do it on a big vessel than a very, very tiny vessel. Especially if it's a very tiny vessel, one of the risks of doing it on a very tiny little thing is actually you push the clot further, and that's really, really bad. So you usually do it only with large vessels like an MCA, and you can also use it in conjunction with a clot busting medication. Okay, so essentially you feed this catheter in to the vessel, and then you kind of grab it with a stent, like a little net, and then you pull out that clot out. Okay, so I'm going to show you a quick little video because I think it's actually pretty cool. I've seen it a couple of times, but whoops, let me grab this.
This animation shows how we perform stroke intervention in patients. When a patient is having a big stroke, there's typically a blockage of one of the major blood vessels to the brain. That blockage is often caused by a blood clot that forms somewhere else, like in the heart or in the carotid artery in the neck, and then breaks off and travels up and plugs up one of the main arteries going to the brain. So that part of the brain is at risk of dying because of what you can see here. Place it in the carotid artery in the neck, that's the blue catheter. Through that catheter, we take up a smaller catheter, a microcatheter, and we catheterize the arteries inside the brain, the carotid artery, and into the middle cerebral artery. You can see the clot within the middle cerebral artery, which supplies blood to that half of the brain. So we bring up our microcatheter all the way up into the middle cerebral artery in the brain and cross the blockage. Once we're across the blockage, we bring up a mechanical thrombectomy device, which is kind of a stent on a stick kind of configuration. It's a stent-like device that we unsheath within the clot in the blockage. You can see the stent is opening up and actually restoring blood flow immediately. We then give it about 5 minutes, allowing the radial force of the stent to open up outward and allowing the clot to extrude within the lumen or inside of the stent. After the 5 minutes is over, we inflate a balloon in the carotid artery in the neck, which arrests flow, and then we pull back the stent retriever device with the clot entangled inside it into that balloon catheter. The purpose of inflating the balloon in the carotid artery in the neck is to reverse flow from the...
Okay. So essentially, they just with EVT, they expand the vessels up a little bit, grab the clot, and they pull it slowly back. And then hopefully it allows for blood flow to come back again. All right, so that's just my last slide, but I think we just made it at 10 o'clock. So thank you so much for listening. Hopefully you enjoyed this talk. I'm not sure if we have time for a Q&A. I'll stick around for like maybe a few more minutes if you have any questions, but really appreciate being invited to give this talk, and thank you all for staying and being such great participants.
Okay, thank you so much, Doctor. I think we can make room for 1 to 2 questions. Okay, can anybody, or is anybody like interested in asking? Yes, Lila or Lila, that is the last workshop for today.
Oh.
Lots of thank yous. Thank you to everyone who joined. Yes. Any more questions? Okay, I guess we don't have any more questions. I would love to communicate to all of you. Okay, Jamila.
Okay.
Okay, we're capping this at 2 questions. Okay.
I asked a question earlier about if the brain was a consensus, different function. Oh, I guess like if the different functions of the lobe work together, as you probably imagine, yes, they do. Like not every lobe works individually. There's a lot of overlapping functions, but you know, a lot of the historical studies have shown that certain lobes have more specific sort of functions, but they all integrate with one another, right? And there are studies to show that if you damage one of the lobes, other lobes can slowly take over through neuroplasticity as the brain is sort of like learning on its own. Do you do research while also being a part of residency? I could, yeah, I will. Part of my residency training is that I have to do a little bit of research again, but there's a lot of flexibility in terms of what I want to do. I like teaching more, so I teach a free neuroscience course on the side in the summer, so some of you are part of that neuroscience class. I try to offer it every single year in the summer, so I try to do that on my own time. So I know some of my students are here because they were interested in learning more about neuroscience.
Okay.
And yes,
Do you think we have one more time for this last question from Matthew?
sure. Hello, sir. Are you a medical doctor or your career growth in neuro that's giving you this residency? I don't know if I understand the question per se, Matthew, but yes, I finished my medical training. So again, just kind of brief background. I did my undergrad in neuroscience, and then I did my master's in neuroscience. And then I decided to go into medical school. So I am currently a training neurology doctor. So hopefully that answers your question.
Thank you all for the questions. For any more additional inquiries, I think Dr. Edwin would encode his email in the chat. There you can send your additional questions and any other concerns and any other interesting like inquisitivities of the mind about neuroscience.
Yes, and I had a couple people just messaging me quickly about the neuroscience course I offer. I try to offer it every single year. So there is a nonprofit organization called STEM Fellowship. So just follow that. I can also just put in my Instagram if people are interested in just connecting with me there. If it's like a quick little question on the DMs, but also my email as well. So there. All right, thank you.
Okay, thank you all so much. I'll be stopping the recording now.